Craniosynostosis is when the sutures of the skull close early, which causes the bones to fuse. So our skull is made up of multiple bones that have these sutures running between them that allows the skull to grow to allow the brain to grow. When these sutures fuse, what happens is that it restricts the growth of the skull, which then restricts the growth of the brain. There are multiple different types of synostosis, with 4 sutures that are the main ones we think about. The first one, and the most common, is sagittal synostosis. Sagittal synostosis is when the sagittal suture, which runs right here, closes. This causes a very long and narrow head. Other sutures that commonly confuse are the metopic suture, which is the suture that runs in the forehead here. The interesting thing about the metopic suture is that it's the only one of the major sutures that is normal to close in the first year of life. So with that, we will often see patients who will have a ridge in that region, but the forehead is not shaped like a triangle. In those cases where the forehead is round, we typically do not recommend treatment. Treatment is reserved for the patients where what's called trigonocephaly, where the forehead really resembles a triangle and the brain growth is restricted. The other common synostosis is what's called coronal synostosis. And the coronal sutures run from here across the top, and there's actually 2 of them. So either suture can fuse or both can fuse. If one fuses, then typically the face is misshapen and the nose and chin point away, and the eye on that side is actually affected as well. Lambdoid synostosis is the least common and is fairly rare. In all, about 1 in 2,000 live births has craniosynostosis, so it is fairly common in the population and something that is regularly dealt with. Craniosynostosis is diagnosed first by either the parents or pediatrician noting an abnormal head shape. As mentioned earlier, the head shapes for synostosis are fairly characteristic based on the suture that's fused. One important distinction is determining craniosynostosis versus positional plagiocephaly, which is where the head gets misshapen from laying on it rather than the bone being fused. Now that's something where there is a very normal appearance for each of these things, so someone with experience is usually very able to distinguish these. Sometimes, in specific cases, it may require imaging to determine what is fused and if there are things that would require intervention, but in most cases we can at least make a preliminary diagnosis solely based on the clinical examination. Typically, we like to see these patients as early as possible because there are different treatments that we can offer in younger children that cannot be done once they're older. Treatment of craniosynostosis is typically surgical, and there are a number of different options for how it can be treated. There are the lesser invasive options, which are typically done less than 3 months of age, and the more classic open surgeries that are done when the child is older. For the less invasive options, typically we use an endoscope to assist, and the goal of this surgery is primarily to remove the involved suture. So we make small incisions and then separate the bone from the covering of the brain and cut the bone out. The patient then is followed in the hospital overnight and typically goes home the next day. Then something needs to be done over time to help reshape the head. In most cases, this is a helmet, but in certain instances, you can also do springs, which prevent you from needing to go for helmet appointments, but does require an additional surgery to remove them. If the child is older, then typically it's an open remodeling where it's a larger incision and we remove all of the bone and then reshape it and replace it. And this is typically done with a plastic surgeon as well. So after the more minimally invasive operations, the children are typically watched overnight and often go home the next day. They tend to return to normal activity fairly quickly. With the more open procedure, they're typically in the hospital a little bit longer, but usually in follow-up have also returned to normal fairly quickly. So the typical follow-up care obviously depends on which operation was done. For the less invasive procedures, typically the patients leave the hospital the next day. We would tend to see them back in about a month to make sure everything is healing appropriately, and then usually every 3 months for the first year. If they have a helmet, then they are seeing the orthotist fairly regularly for refitting and adjusting their helmet as well. Once they're beyond that point of a year, typically the follow-up spaces out, although we will continue to follow them as this is something that can recur. So we follow them at least until they're about 6 years of age to ensure they don't develop any problems later. For the most part, most of the patients do very well and don't have problems in the long term. With our craniofacial clinic and pediatric cranial reconstruction center, we provide truly multidisciplinary care. We work with specialists from a number of departments across the institution to ensure that each step is appropriate, from diagnosis, including limiting the amount of radiation that may be required to make the diagnosis, to offering all of the different possible treatment options, and then providing exceptional care by our nurses and operating room staff to keep the patient well after the surgery or treatment has been completed. As there are multiple treatment options for craniosynostosis, we work with patients and families to determine the best possible treatment option to help them make the right decision for their family.